Rajiv Agarwal for giving me an opportunity and giving me a topic which very few of us have actually heard about. It's a very, very interesting topic. It's about CETP inhibitors. We have all heard of CETP inhibitors over the years and actually sort of given it up for good. But Dr. Agarwal decided to change the clothes of this particular topic and give it to me as a different color and different form. And I shall be trying to do justice to it in the next probably about 10 minutes. I'll try to squeeze it in. Now, how many of you can recognize this beautiful village? This is the beautiful village, which is the basis of atherosclerosis and atherosclerosis becoming a lipid-centric disease. This is the Framingham village, wherein the first time there was a direct relationship with elevated LDL cholesterol and an inverse relationship with HDL cholesterol was found out. So when this came into the picture, LDL has always held the key, but we have always wondered what to do with HDL cholesterol. And that is when we started looking at the CETP inhibitors. What is the CETP? Basically, CETP is a glycoprotein that is synthesized in the liver, and it promotes a bidirectional transfer of the cholesterol esters and triglycerides. Now, what it does is in an HDL particle, it takes the cholesterol and puts it inside the VLDL particle, which is an ApoB containing particle, and in turn gets back the triglycerides. So net result is when the CETP acts, what happens is the cholesterol content of the HDL comes down and there is a low HDL cholesterol. Similarly, in the LDL cholesterol also, it can do this transfer, and CETP basically means that it transfers the triglycerides and the LDLs reversibly. That is what happens. So you can try to block this by CETP inhibitors. The interest in this particular topic basically came in the genomic studies. There are two major studies. One is which said that high density lipoprotein caused by an increase in cholesterol transfer protein gene, and one more genetic study. Both said that if you have a genetic mutation of the CETP, you can actually have an increase in HDL cholesterol. That's the first thought. The second thought is to try to correlate this and try to figure out if this is going to be effective in preventing atherosclerosis. Then the subsequent genotypic studies came where they found the association between the CETP mass, lipid levels, and coronary risk. And then there are also interesting studies trying to do a Mendelian randomization study to find out the risk of myocardial infarction. So this developed more and more interest in CETP, and subsequently there have been studies that have been going on. Several of these studies have come in, and all these genetic factors and studies have clearly shown that the higher LDL, higher HDLC, and lower reduction of LDLC and ApoB were associated with a lower risk of atherosclerotic, and this is associated with the variants of the CETP gene. So research started getting in and trying to figure out how to do and increase this reverse cholesterol transport. I think all of us have learned from our biochemistry days that HDL cholesterol improves the reverse cholesterol transfer. Basically, what happens is it removes the cholesterol from the peripheries and brings it back to the liver for removal. Now, the first drug that came into the market was actually torcetrapib. And when they looked at the drug, the interesting results were that it increases the HDL by 72%. But when you looked at the clinical result, you should expect an improvement. Look at what happened. Major cardiovascular events were actually higher. Look at the blue bar, which shows the medial cardiovascular events are higher. Not only that, death from any cause, meaning all-cause mortality, was also higher. Now, this is the major result of the Illuminate trial or the torcetrapib trial. But this is not the interesting part. The most interesting part is here. Look at the torcetrapib trial. It showed a 24% reduction in LDL cholesterol, which went totally unnoticed because of the fact that the negative effects of the trial were there. So what was the reason for torcetrapib to fail? You increase HDL, we know it should benefit, but it did not show the benefit. So was it because of the increase in blood pressure, increased aldosteronism, or reduction in the potassium, or was it death from sepsis, which was seen in these group of patients? They were not very clear, but a lot of these postulations and came in, but still subsequently the second trial came in, which is actually the DAL outcomes trial with the dalcetrapib, which is a molecule. Now, this was a modest increase in HDL cholesterol. It increased it by just about 31 to 40%, but there was an increase in the C-reactive protein. And if you look at the results of this trial, they found out that there was no difference in the primary efficacy between the placebo in the red and the blue one, which is dalcetrapib. All-cause mortality, more or less similar, no significant difference. So this study was actually stopped for futility. So what is going to be the future of this? Why did not work? There was only a moderate increase in HDL cholesterol, and they felt that is when the concept of the dysfunctional HDL came in. Remember the slide that Dr. Rajiv Gupta had put in, wherein he said there is a sweet spot between 40 and 70 of HDL cholesterol where it is functional. Less than 40, it is dysfunctional. More than 70, it becomes dysfunctional. And in fact, the European Society of Cardiology went ahead and said, if your HDL is more than 90, it can be purely dysfunctional and can be a harmful factor. So the results so far have shown that even if there is an increase in the HDL cholesterol, a reduction in the LDL cholesterol, even if it's about 12% with the torcetrapib or it's slightly higher with the dalcetrapib, it still is not going to be clinically beneficial. So what is going to be the analysis? One of the analysis that came up was they said that what all these trials did was use the Friedewald equation, which actually used the triglyceride values. So the ratio of the triglyceride to cholesterol is actually altered. And when you have this particular molecule coming, you get a wrong value of LDL cholesterol. So they have said that beta quantification reference is going to be a more accurate method to find out of LDL. Obviously, the HDL is now out of the picture because we have said that the HDL cholesterol is going to be a dysfunctional HDL cholesterol. So is the LDL going to be relevant, or are we overestimating the reduction in the LDL cholesterol? So the next drug that came in was actually called ezetimibe. The phase 2 trials with the 30, 100, and 500 milligrams over a 12-week period, they wanted to look at the values and look at the HDL increase, 128% of the maximum dose, and look at the reduction in LDL cholesterol, which was actually 35%. So here you have a drug with very good results. And when you look at the overall results of these drugs with the HDL and the LDL cholesterol, significant differences were found compared to even statins. Even patients who are on rosuvastatin had a subsequent reduction of the LDL cholesterol. What about the side effects? No major subsequent side effects were there. The blood pressure did not increase much. The aldosterone levels, the creatinine kinase, the drug-related adverse effects, nothing was really significantly different. So this kind of enthused the people more. And then the outcome trial, which is the Accelerate trial, came in. Accelerate actually showed that the HDL cholesterol went up by 133%. But look at the LDL cholesterol. It was a nearly 31% reduction in LDL cholesterol. So what would you expect? You would expect a fantastic result. Look, we are looking at results for about 26 to 30 months. The mean duration of the study was about 26 months. But in the Accelerate trial, look at the results here. They are more or less same. It accelerated trial, but decelerated the results. There's not much of difference at all. Look at the primary composite endpoint, more or less the same, and look at the all results. Nothing really showed much of a difference. So this trial also did not show any significant effects. But some other interesting points came up in this trial. Look at the last portion here, the mean LP little a, there was a 22% reduction in LP little a, which was not found so far. So some interesting points were cropping up, but the study was still a negative trial and nothing seemed to be working. So the next trial came where they studied first initially the DEFINE trial was first done just to find out if this drug is going to work before an outcome trial could be done. So this is called the DEFINE trial with anacetrapib, one more drug. No changes in blood pressure, electrolyte, aldosterone, CK levels or liver function were found. So this drug was found to be safe. Once it was found, they also found that there was a small benefit in the cardiac trial because overall results were good, and actually the revascularization was reduced in these group of patients. So some kind of benefit was found. So they went ahead and tried to look at a larger trial. So how large should we go? They looked at 30,000 patients. It's a multi-center trial, 30,000 patients with 100 milligrams of anacetrapib and a scheduled follow-up of 4 years, thinking that that would be a good time to show results. And look at the LDL reduction. The direct method LDL reduction was 41%. But if you look at the beta quantification, it was actually 17%. Now, what is the direct method? In most of the places, we do an enzymatic or a homogeneous method, wherein here the LDL cholesterol reduction was 41%. Again, look at lipoprotein A reduction, 25%. HDL increase is 100%, but I think we are not looking at it anymore. What about the results of the trial? Results of the trial were beautiful. These curves start separating beyond 2 years. They take a long time to separate, but statistically significant results were not found much. Major vascular events had come down by about 7%, and there was a statistical significance here. But the results, when you look at it, the onset of the first clinical event seems to be getting clinical benefit after 2 years. Overall benefit, if you look at it, is very interesting. 0.25% of absolute benefit per year for 4 years. Actually, this was exactly similar to what the IMPROVE It trial showed. So some interesting data was happening. So they looked at the pharmacokinetics of the anacetrapib in the DEFINE trial actually, and they found out that even after 2 years of stopping the drug, anacetrapib still stayed in the blood. So it seems to be sticking to the, not in the blood, but sticking to the adipose tissue. And it seems to be working at low levels of pharmacological activity. So what happens to these trials? So the next phase of the REVEAL trial was a follow-up data. Look at this, this is a 4-year trial. After which, after 2.5 years, subsequent data showed the curve started separating. Now, mind you, the important point here is the drug was not given here. Drugs were stopped at 4 years, and despite not giving the drug, there was a separation of the curves. And look at the results. The results went up to 12% from about 8% there. And this was very statistically significant. And the 9% in-trial reduction in events was exactly similar to what the CTT trial showed, which is 17 milligrams LDL, non-HDL reduction. So what it seems to show, the HDL has no impact. The reduction in the LDL and the non-HDL cholesterol is the one that is very, very important here. Now, how does this work? There has to be some mechanistic study to say. Now, what happened? The niacin increased the HDL cholesterol. Anacetrapib also increased HDL cholesterol. What does it, in what way does it differ? Some studies have shown that only anacetrapib HDL increase led to the cholesterol efflux. While there it was a dysfunctional HDL, here it was not a dysfunctional. To some extent, this is there. It's not strongly proven, but there is some difference between the increase in HDL between the anacetrapib and the nicotinic acid or the niacin. The other interesting point is that there is a reduction in the PCSK9 activity. PCSK9 transcription has been reduced, and this may be one of the reasons why the LDL cholesterol comes down. So you have a little bit of PCSK9 activity also with anacetrapib, and there is some data to prove this effect. To summarize the effect of all the drugs so far, the first two we have seen, if you look at anacetrapib and ezetimibe, the LDL cholesterol reduction is about 40%. Look at ApoB, that also comes down by 21 and 26%. So there seems to be a significant reduction in the conventional risk factors. Dr. Rajiv Agarwal is very clear in saying that LDL is the first, and LDL reduction is about 40% in these group of patients. Now the accelerated fail and the REVEAL succeeded. What is the difference despite 40% reduction? The main reason was very, very simple. You look at the data. They studied just 12,000 patients in Accelerate. It was 30,000 patients in REVEAL. And the events were much higher, obviously, because of the higher number of patients. Not only that, the duration of the study was 50 months. So longer duration of follow-up is going to be required to show mortality benefits. We have already seen this in the PCSK9 trials where the MACE reduction is more important. Probably if you're going to look at a longer duration, you're going to show mortality benefits. And I think it's very clearly shown in these group of patients. Now, after all this, the next drug came in, which is called obezitrapib. Now, obezitrapib was studied in two doses of 5 milligram and 10 milligram. And look at the reduction in the HDL increase and the LDL increase. Both were fantastically there. And this drug was proven to be very, very effective. Now, what is going to be happening now is we can't give these drugs alone. Now, these are the multiple mechanisms in which the cholesterol lowering can happen. The conventional method here is increasing the receptors of the LDL in the liver, which is through the bempedoic acid and statins, which act through the same pathway, reducing the synthesis of cholesterol. Then you have the inclisiran and PCSK9 inhibitors, which act through a different pathway. Ultimately, everything works here the same. The other one is the Niemann-Pick cell, the ezetimibe, which acts at the Niemann-Pick level. And now we are looking at CETP. Now, what happened if you try to combine all these drugs? Obezitrapib had a very interesting trial called the ROSE trial, where obezitrapib was given on top of a high-intensity statin. Now, what happens when you give it a high-intensity statin? Look at the change in LDL cholesterol at 12 weeks, 6.4% reduction. Obezitrapib only 47% reduction. With ezetimibe, there was an additional 63% reduction in the LDL cholesterol within 12 weeks. And look at the persons who are achieving a target goal of 55, which is the European Society of Cardiology guideline. And this was, nobody reached with the placebo. 42% reached it with obezitrapib. And if you combine it with a high-intensity statin, obezitrapib and ezetimibe, nearly 87% of the patients achieve target. So here we are looking at some fantastic drugs that are going to help you achieve the target, which is going to be very, very important in clinical practice. The common question that has been asked with statins is, does it increase the new onset diabetes? Well, it's the reverse here. Probably if you use this drug, there is a 12% reduction in the risk of diabetes. So that makes it a good countering factor when you start giving statins. Now, this is a very interesting point from the 2019 article by what this shows is just 2 points. One is, if you look at the HMG-CoA's reduction variants, they have been lifelong reduction. They have a much better benefit than the statin trials. Very clear. So you have a shorter duration of 4 to 5 years, the reduction is going to be there, indicating that longer the duration of LDL lowering is going to be important. Now look at the CETP inhibitor trials. Now let's go look at the CETP variants. There are 2 kinds of variants. One, where there is an increase in HDL, and 2, there is a reduction in LDL. That is effective. But there are some variants where only there is an increase in HDL without a change in LDL, there is no benefit. Now, this is the similar point that we are seeing with torcetrapib, no reduction in LDL. In fact, there's no increase in, no reduction in LDL, and there is an equal value in dalcetrapib, evacetrapib, and the anacetrapib showed a reduction in LDL. So what is important is the reduction in LDL, and the duration of therapy matters to make it statistically significant. So ladies and gentlemen, to conclude whatever I have said so far, CETP inhibition has genomic validation through multiple Mendelian randomization studies that we had shown earlier. Clinical validation through the results of the REVEAL trial has been found to show significant reduction. The REVEAL follow-up has clearly shown a statistical significant increase in reduction in the MACE events, despite not giving the drug for 2 years. The results of the REVEAL trial followed that the regression equation is important. The regression is not based on the HDL cholesterol. It is based on the LDL and the non-HDL cholesterol. CETP inhibitors reduce cardiovascular risk by lowering of atherosclerotic lipoproteins. Now, finally, this is the last slide that I have to put. The emperor changes his clothes actually means that the emperor was fooled to believe that he has changed his clothes while he had actually not wearing clothes. The little boys laughed at him and told him that it is not there. It's a story by Anderson. It's there on Wikipedia. Maybe you should read it to have some fun. Thank you so much for the patient listening, and thanks to Dr. Rajiv Agarwal once again.